Yes, sir, I'm opening.
Yes.
Hi, Mamta. Hi, Chaturbuj.
Hello, madam.
Hi. Hi, Sangeeta. Good
Hi.
evening.
Good evening.
Hi, madam. How are you?
Yes, all well.
The room is open for the attendees, so we are visible and audible to the attendees.
Maybe we'll wait for 2 minutes before we start so that may attendees are joining.
Yeah, sure.
The session is live on the YouTube also. So I think we'll start. So very good evening and welcome to this fourth session of our Indian Academy of Neurology Epilepsy Summer Course. So after the discussions on the classification of the epilepsy, medical management of the epilepsy, and management of the epilepsy in women, we have now moved to the clinically important topic of withdrawing anti-seizure medicine in patient who become seizure-free, either with the medicine or after the surgery. And all the neurologists and who are seeing epilepsy patient would agree that it is a bit of a difficult question to answer. And every time when the patient who is seizure-free for 2 to 3 years, there will be a dilemma whether to withdraw the medicine or when to withdraw medicine in these patients. To answer some of these questions, we have one of the pioneers in this field, Professor Kees Browns from the Utrecht University Hospital, Netherlands. And it has been a privilege for us that Professor Brown has accepted our invitation and has accepted to be with us and discuss this important topic. Professor Brown is a professor and head of the Pediatric Neurology Department at Utrecht University Hospital, Netherlands, and is working in the field of pediatric neurology for last 25 years. He has been a past president of Dutch Society of Pediatric Neurology, past president of the organizing committee of World Congress of Child Neurology, and on several European task forces on epilepsy and pediatric neurology. He has more than 250 publications, especially focusing on the pediatric refractory epilepsy, seizure and cognitive outcomes after epilepsy surgery, and particular to our today's topic of post-operative anti-epileptic drug withdrawal in patients who become seizure-free. So we are really privileged to have you, sir, and thank you very much for accepting our invitation. For the discussion on the Indian perspective and then our management of the patient in India, we have two panelists, eminent panelists, Dr. Nirmal Surya, and I think everybody in India knows him. He's a senior consultant and past president of the Indian Academy of Neurology, associated with various bodies of the epilepsy, stroke, and neuro rehabilitation. And he has received too many awards, too many to enumerate. So we thank you, Professor Surya, for accepting our invitation and be with us today. And second panelist is our chairperson of Epilepsy Subsection, Professor Mamta Bhushan Singh, who is a professor at prestigious All India Institute of Medical Sciences, working in the field of epilepsy for last 20-25 years, with a special interest in primary care of the epilepsy and untreated epilepsy. So we thank you, Professor Mamta, for being with us. And this with short introduction, I would invite Professor K.S. Brown to deliver his talk on the anti-epileptic drug withdrawal. Thank you, sir, and over to you.
Well, thank you very much for this very kind invitation, particularly coming from you, who has a lot of experience in the topic of drug withdrawal, as I will refer to later on. I'm first going to share my screen with you, and just to assure that everything's working the way it should be, could you confirm that you see the slide now?
Yes, we can see it, but only, sir, we can, yes, that is perfect.
Now it's okay? Okay,
yes, okay.
Then I'll
Perfect.
start. Yes, okay. So we'll talk about withdrawing drugs, and you said it's a difficult dilemma and a difficult question, and it will remain a difficult question even after this talk, obviously, but I'll try to give you some clues perhaps, because indeed, at some point, many patients will reach seizure freedom, and the question arises, what do we do with the drugs? Should we continue? Should we withdraw or not? And what are the risks and the benefits? So one of the first things people would do is take the most recent recommendations on the topic. And that is, in this case, the one from the American Academy that was published in Neurology 2021. And to be honest, that's rather disappointing recommendation, because it doesn't really give you the answer to the question. The conclusions from the recommendations are, first of all, that the long-term risk of recurrence is possibly higher in adults who are seizure-free for 2 years and taper versus those who do not taper. And then, even more complex, in children, there is probably no significant difference in seizure recurrence if you taper after 2 versus 4 years of seizure freedom. And another one, very complicated, there is insufficient evidence of significant difference in recurrence rate between those who taper after 18 months or after 24 months of seizure freedom. So this is the evidence, apparently, according to the recommendations. So does it really help? I'm not so sure. We do, of course, agree that there may be benefits of drug withdrawal. And it's quite logical that if we can withdraw medication, we can stop the side effects, other adverse effects, teratogenicity, interactions, cost monitoring, and even more important, this will eventually enable to reach cure, being seizure-free, medication-free. Cognitive and behavioral side effects are very important. Developmental problems in children are very important. As a pediatric neurologist, I'm daily confronted with the cognitive problems of having epilepsy and using medication in children. So I'd like to focus a little bit on that part of the story. And if indeed drugs have cognitive side effects, it is to be expected that if we withdraw medication, that cognitive functions will improve. And this was actually nicely shown in the trial done by Dr. Lossius in adults who were seizure-free, and they randomized between withdrawal or continuation of one drug, and found that drug withdrawal led to an increased number of patients with completely normal neuropsychological test results. They saw an improved executive functioning and a slight improvement of verbal memory. And similar results were identified in children with an increased alertness, activation, and psychomotor speed. In the postoperative situation, actually, there have been some studies on the IQ change that may happen after epilepsy surgery. And they were meta-analyzed very recently, where it was shown that if patients reached drug freedom, children, versus those not being drug-free, the change in IQ was significantly higher in those that withdrew medication. To really correct for all possible confounders and all other causes of change in IQ after epilepsy surgery, we have also addressed this topic a few years ago in the European Time to Stop study. I will come back to that study a little bit later, but in that study, we had the opportunity to look at the IQ of 300 patients, children, who were investigated before and after epilepsy surgery. And we looked at the change in IQ and the eventual IQ in these children, and then tried to investigate how the drug policies related to these outcomes. And we found indeed that independent determinants or predictors of IQ and change in IQ were having started to reduce medication or even completely stopped all medication, and also the number of drugs reduced. So the more reduction of drugs, the better, the higher the eventual IQ, and the more increase in IQ. And this was confirmed in a recent study we did together with the German group, trying to build a prediction model of cognitive outcome after epilepsy surgery in children. So we looked at the children, almost 500, with IQ data before and after surgery, developed it in the German cohort and validated in the Utrecht cohort. It's quite a complicated scheme, but the essence here is that if you look at the eventual IQ and then at the variables that were significantly related to the eventual IQ, again, being free of drugs after at the latest psychological investigation was very significantly related with the eventual IQ. So I think the benefits are quite clear of withdrawal of medication. Obviously, the problem is how do the benefits relate to the risks for each individual patient? And I'd like to start discussing this in the medically non-surgical patients, and then after that, I will switch to epilepsy surgery and how things may be a little bit different in that case. So when reviewing and summarizing the risks of drug withdrawal in general in seizure-free patients, you can see that in the blue, the medical group, the recurrence risk gradually increased a little bit to around 30% after 4 to 5 years. The question obviously is, how do these relapse risks relate to the risk in the patients who were seizure-free but continue drugs, because they also may have a recurrent seizure despite staying on drugs. So what is the evidence we have from controlled trials in this? Well, first of all, there's this study in Scandinavia that showed that in seizure-free patients, adults for more than 2 years without seizures having one drug, the risk of a recurrence was 15% if they withdrew versus 7% if they continued 1 year after the randomization. So this is a relatively low risk. So it's a very good outcome population. It's a strict, mild population of epilepsy patients. But this didn't reach statistical significance. Then there's a larger study, but unblinded, but still a randomized controlled trial of over 1,000 patients, particularly adults, the MRC UK study, who were again seizure-free for 2 years. And the question here was whether or not the recurrence risk differed 2 years after randomization. And they saw again that there's an increased risk of those who withdrew. That is a factor 2 higher than those who continued, but this was indeed statistically significant. So based on this data, the recommendations I started the talk with came up with the conclusion that the long-term risk of seizure recurrence is possibly higher if you were seizure-free for 2 years and tapered drugs compared to if you continue drugs. Of course, it depends on the number of risk factors that patients may have for a relapse. And in that same publication a few years ago, we looked at the risk factors that had been published then in the literature and where these risk factors were actually identified as independently significant in a multivariable analysis of prognostic factors of a drug withdrawal relapse. So this is a quite complicated list of risk factors. There were actually 25 risk factors identified from the literature. And you see that this is not very consistent. So for instance, you see here the number of studies that included a variable or a predictor in their analysis. And here you see the number of studies that actually identified that predictor to be significantly related. So the problem here is that the results are inconsistent. In some studies, the factor is significantly related, and the other studies it was not. The study cohorts really differed in terms of sample size, disease characteristics, and in each of these multivariable models, different factors were selected to be included in the model. And none of these studies included all possible variables to try and identify those variables that were independently related to outcome and how they were weighed against each other. So it's very difficult to use this kind of information if you want to counsel an individual patient. And just to give you an example, if we have two patients, both being 3 years seizure-free with a focal epilepsy and using one drug. So the one would be a child, 9 years old, with Rolandic epilepsy, select, that had 6 seizures, had a rapid effect of one drug, and has now a normal EEG. And the other patient is a 32-year-old woman with an onset at the age of 20 with a focal epilepsy. We don't know the cause. There is an intellectual impairment. She had 12 seizures before drugs, and the EEG showed epileptiform abnormalities. So they are both 3 years seizure-free. They both use one drug. But obviously, they will have most likely different relapse risks. So how do you counsel these patients just based on group averages? Because these kind of relapse graphs represent the average of a group. It's not always useful to use that in individual patients. So the recommendations also state that it's actually unknowable if the patient continues to have epilepsy or not once epilepsy is masked by the drugs. And therefore, it's very important that the patient is part of the medical decision-making, specifically if there's equipoise, if you don't really know what will happen, what the chance will be of drug freedom, seizure freedom or seizure recurrence. And some other studies also came up with this very important recommendation that the individual risk for a specific patient should be tried to identified, and patients should be counseled as such. Because only then they can truly balance the benefits versus the risks for them. So individualized risk estimation is a very important theme, together with the weighting of the benefits versus the risks, and the fact that you have to make a decision together with the patient is not anymore an advice that should strictly be followed. It's something that you have to decide on together. So to come up with the topic of individualized prediction modeling, which is getting more and more relevant in medicine in general, we can build prediction models based on existing data, patient data, groups of patient cohorts with known outcomes. We can collect data from retrospective cohort studies. We can try to collaborate with other centers. And if you collect those data, you can come up with an individual participant data, or IPD, meta-analysis. And this meta-analysis will lead to a development of a model, a prediction model, which can then be validated in other cohorts to see how accurate the prediction model is. And you can actually make an online tool from it so that everyone can use it in the individual patient in their outpatient clinic if they want to diagnose or prognose or estimate the risk in a specific person. Such a model, such a prediction model, has to have, of course, a discriminative ability. It has to be accurate. And this is reflected by a number which is called the C-statistics or concordance index. And it's similar to the area under the curve of an ROC curve. And in general, it's said that a C-statistics of 0.5 means just flipping the coin, so no better prediction than just chance. 0.7 would be a good model, and 0.8 would be a strong model. Just good to keep these numbers in mind, because we're going to refer to these a little bit later on. And over the last few years, there's an increasing number of prediction models that are available also online to be used in individual patients. And Some of these were developed by our team, the ones that I here listed with the references, and the ones, of course, that I'm going to discuss today all relate to the risks after medication withdrawal. The first one is probably the one that is best known, and some of you may actually use it. It's a model that is developed in 2017, and it's online since then. And it's still being used, I think, 20 to 30 times a day worldwide. We can look that up. So it seems to be a tool that may be useful in everyday clinical practice, with all its limitations, of course. This is the paper of the model published in 2017 in the Lancet Neurology. And it was based on a meta-analysis of individual participant data. We first looked in literature to identify cohorts of patients where we knew what happened with their seizure outcome after they withdrew medication. We contacted the authors and invited them to collaborate with us. And by doing so, we got the data from almost 1,800 patients. And these were, I will not go into the methodological details, but these data were entered in a model, and this led to the development of a so-called nomogram, which is in the paper, where you can assign a specific number of points for each of the variables. And that would add up to a total number of points that relates to recurrence risk. So, for instance, the epilepsy duration would lead, in this case, after a year, to 2 points. Being seizure-free for 2 years would be 20 points, etc., etc. And by doing so, you can see the eventual total number of points that correlates with the recurrence risk at 2 and at 5 years. And to make things a bit easier, this is now built into an online risk calculator. You can freely have access to that. It's epilepsypredictiontools.info. You can actually find other tools, the ones I was referring to before, also on the same website. And I have it on my iPhone, and I use it during the consultations very often. It's easy. You just enter the predictive variables for each patient, and at the end, you just push calculate, and you get the numbers of relapse risk for that patient and the chance the patient is still seizure-free, independent of drugs, at the end of the line. So longer-term seizure freedom with or without medication. So talking about the accuracy and discriminative ability of the model, again, the C statistics are around 0.17. The probability and the observed proportion of relapses correspond rather well. And this kind of model actually can differentiate between the patients. The 2 patients I was just referring to are again here, and now the model results are shown, where you can clearly see that the child with the selects have a relapse risk of 17% versus the woman with intellectual impairment that has a 75% risk of relapse based on the model calculations. So this model was developed in a large cohort. What we did when we developed it, we internally cross-validated it. So it means that we had 10 cohorts. We developed a model on 10 cohorts. Then we left 1 cohort out. We redeveloped the model on the remaining 9 cohorts and tested it on the one that we left out. And we did that 10 times for each of the cohorts with similar kind of C statistics. Optimally, such a model is also tested externally in other studies, which has been done now 3 times. There's 2 Chinese studies using the model, coming up with more or less similar C statistics around 0.70, where in one, the 2-year model was better, and the other, the 5-year model was better. And very strangely, recently, an Italian study also validated and found a very low area under the curve of only 0.5, suggesting that the model doesn't do better than flipping a coin, which is counterintuitive and probably has to do with differences in cohorts between that specific Italian cohort and the large group of 1,800 patients that were derived from 10 different cohorts based on which we developed the model. So for some epilepsy syndromes, of course, we know that the risk is probably much higher of recurrences, and they cannot easily be used with such a model. So that's why we thought it would be wise to consider similar efforts for specifically JME. And with the same kind of approach, we did an IPD meta-analysis from data of 2,500 patients from 24 studies in the literature, where we collected again the data by agreement with the authors of these studies, and built a prediction model. First of all, to predict the drug resistancy in JME, and also in a smaller cohort of patients who actually try to withdraw medication, try to come up with a prediction model to look at the individual risk of relapse. And again, we have the nomograms, and we see again a similar c-statistics of 0.70. And this was also internally, externally cross-validated. It's interesting, by the way, to see that this model suggests that in some patients you can safely try to withdraw medication with JME. The patients are very long time seizure-free, and at an older age, they may be good candidates to try. But that's not the topic for today. So now I wanted to switch from the medical situation to the surgically treated patients, and go again at the recommendation paper of the American Academy, see what they write about what we know in terms of relapse risks in patients who were operated. And what they come up with is the recommendation or the conclusion that clinicians, again very vague, they may discuss that the risk of relapse is uncertain due to the lack of evidence. There's insufficient evidence to support or refute that recurrence rate at 1 versus 4 years is not significantly different from those who continue drugs. Again, very complicated to read this. It suggests that we don't know actually what the risks are or what you should do, which is based on the fact that the papers that were selected for this recommendation were very strictly according to the levels of evidence, rigorous evidence to come up with conclusions. But of course, we have many more studies that give us information about risks that were not included in this review. So I'm not very happy with the final conclusion of such review that is only based on high-level evidence, which is few in this topic. What we do know that if you would compare the risk after withdrawal following epilepsy surgery versus the risk of a relapse in those who continue medication, that there are not many differences. There's one prospective study in 60 adults who were seizure-free, where it was proposed to withdraw, but the patients themselves decided. Not a big difference in relapse rate after 5 years. Another study in temporal lobe epilepsy, where patients who were on polytherapy versus the ones who were on carbamazepine monotherapy had no differences in relapse when they withdrew or continued medication. And then, very interestingly, a study that pooled the data of 16 previous studies and found that the relapse risk is much lower in the patients who withdrew medication compared to those who continue, which is logical because these are all retrospective cohort studies, most of them at least, and the patients who withdraw obviously have a lower risk profile, otherwise they wouldn't dare to withdraw, or their doctors would not advise them to withdraw. If you already suspect a patient to still have epilepsy, and you would advise them not to withdraw medication and continue. So it's logical that the ones who withdrew had a better outcome than the ones who didn't. It also shows that we don't have truly comparable cohorts in terms of disease characteristics other than the drug withdrawal policy to actually understand and calculate the true difference in policies in terms of relapse rate. We do know, however, that after epilepsy surgery, medication withdrawal is not very frequent, particularly in adults. You can see here the studies from the European Epilepsy Brain Bank, where we looked at seizure outcomes 1, 2, and 5 years after surgery, and also drug use 1, 2, and 5 years after surgery, specifically for all etiological categories. And in this graph, you can see the difference between children and adults in terms of medication freedom. So in children, it's much more common to withdraw medication for obvious reasons, which I will not go into detail too much, but the risks of a relapse is a little bit higher in adults, but the consequences of a seizure relapse is probably much higher in the adult situation. If you think about driving licenses, you think about professional abilities, psychosocial consequences, the possibility of living alone, unsupervised, etc. versus the pediatric situation where the cognitive and developmental side effects of the drugs are very often an important reason for parents to really claim or urge to withdraw medication. So we do know from previous work that there is no proof that if you withdraw medication after surgery, that the withdrawal itself would affect the long-term outcome. We do know that children withdraw more often. And on retrospective meta-analysis, those who withdraw do better than those who stay on drugs. We don't have truly controlled studies. The average recurrence risk is around 25%. It's a bit lower in children than in adults. And in general, for both populations, once a patient has a relapse and he or she will restart medication, the chance of regaining seizure freedom is around 75%. And because of that, the idea is that drug withdrawal just unmasks incomplete surgical success in terms of still being dependent on medication. So one of the questions we had already 12 years ago was, how long should you wait before you withdraw medication? And it was quite often recommended at that time that patients should continue their drugs at least 2 years after surgery. Finally, you have reached seizure freedom. Don't push your luck and just continue the drugs. That was a general advice. And we were wondering if that was a good advice considering the cognitive effects on the development of these children, as I showed you, and the observation that we all had that if we withdraw medication, children did better. So we found in this study of almost 800 children who withdrew medication that if you correct for confounders, you see that early withdrawal slightly increases the risk of a relapse with around 2% per month that you start or stop your medication later. But the timing of withdrawal was not related to the chance of becoming seizure-free again if you would restart your medication, and it was not related to the eventual outcomes. So whether or not the patient at the end of the line would be seizure-free with or without medication, it was not depending on when the doctor started to withdraw the medication. We did find, as I told you before, that discontinuation of drugs increased the IQ and also improved the change in IQ. So this is what we knew from children. What we know about adults is particularly for the TLE surgical group. This is from Cleveland, a study where 380 seizure-free adults after TLE surgery reduced medication, and they found that the relapse risk within the next 2 years was a little bit higher if the patient withdrew at 1 year versus if they only withdrew 2 years after surgery. But the long-term remission, very similar to the pediatric data, was similar between the early and late withdrawal. Well, Dr. Thor's study here shows similar result, 135 anterior temporal lobe patients with polytherapy, seizure-free at 3 months, starting to reduce until one drug was left. And then, if they were still seizure-free at 1 year, there was the option to withdraw at that time or to withdraw only 3 years after surgery. Where, again, it was found that there was a relapse rate higher when patients withdrew medication earlier, but the long-term remission rate was similar between the groups. And there's another study showing that a relapse risk is a bit lower if you wait a little bit longer with reduction of medication. So in general, these studies have in common that they show that an early withdrawal is a little bit related with a higher rate of seizure recurrence. This is logical because it's inherent to the fact that the patient had shorter proof of surgical success. And in retrospective studies, of course, the ones who had an early recurrence would not be included in the late withdrawal group. So per definition, patients who withdrew later didn't have an early recurrence. So the total recurrence rate would automatically be higher in the ones who withdrew early. So this does not necessarily mean that withdrawal itself is dangerous. It just unmasks, again, earlier that the patient still needs medication. And in all of these studies, there was no influence of early withdrawal on long-term remission rates. So whether or not the patient still needs ongoing drug treatment is identified sooner in case of early withdrawal, but it may also prevent unnecessary long-term continuation of drugs. So again, the question is not based on group level evidence, but for an individual, how can we counsel that individual about his or her risk? So this is again a study from Dr. Thor, looking at 326 seizure-free patients who attempted to withdraw after anterior temporal lobectomy. And they looked at the significant predictors of recurrence, and they defined the score that contained the three most relevant factors: a shorter duration than 20 years of epilepsy, the presence of febrile seizures, and a normal EEG 1 year after surgery. And you can see that there you can make a score for each of the patients, and the score would be ranging from 0 to 3. And the better the outcome profile, the lower the risk of a recurrence, which varied from 0.16 to a let's say 0.6. And it's a little bit more complicated multivariable approach. We investigated the same based on this time to stop pediatric cohort I just referred to, using the same kind of techniques that we used in the medication trial study. And we came up with, again, a tool that can be used with nomograms on the same website, epilepsypredictiontools.info, with a similar C-statistics of 0.7. And then there's a very recent study for adults with an derivation cohort in London, and both internal and external validation that is also available on another website with a similar C-statistics of around 0.7. We have to realize here that these are moderately discriminative models, and they were, in this case, only valid for patients where drug withdrawal was already planned, because it's based on the results of patients who actually started to withdraw medication. You cannot necessarily use this model to see in each patient after surgery what the risk of withdrawal is. It is only the risk to be expected in a patient in whom you already considered safe enough to try and withdraw medication. So going back again at the three key themes here in this topic, it is the shared decision making. And the question obviously comes up: how often do we discuss withdrawal with our patients? And that's quite disappointing. This is a Scandinavian study that showed that of 186 patients who were seizure-free of more than 5 years, only a third had discussed the topic of withdrawal with their doctor. We studied the same in 3 centers with 463 patients who were 1 or more years seizure-free. They had a total of 1,058 visits, and in total, only in 53% of those visits, the withdrawal discussion was documented in the files, and only in 20% there was a plan to discontinue. We looked at how often it was discussed, how often it was discontinued, related to, for instance, age, and how many years the patient was seizure-free. And as you expect, in younger patients, it was more often discussed and more often done. And the longer the seizure freedom, the more likely the patient had a discussion about drug withdrawal, and the more often it was trialed. You can also see that if you would have used a model, which was not available in the time epoch that we did this study, so this is based on data before the relapse risk model was available, you can see that apparently doctors had a good feel of the risk, because looking at the individualized risk based on the clinical data, indeed, the higher the risk, the lower the chance that the patient was actually advised to withdraw their medication. And when we looked at the predictors of a discussion of withdrawal and an attempt to actually withdraw, you can see that, of course, the longer seizure freedom is related. Older generation drugs are more often discontinued, not have a developmental delay, and a lower calculated risk, which was not available at that time, but similar to this graph, was related to an attempt to withdraw medication. Another question would be, how many years do we think a patient should be seizure-free before we withdraw medication? And this is a question that we asked the members of the American Academy of Neurology, both the ones in the United States and the members of the AAN that worked in Europe, and also a specific group of European epileptologists that were part of a European reference network called EpiCare. And you can see here in blue the results for children, in red for adults. And what it depicts is the duration of seizure freedom until start of withdrawal. So we just asked with specific vignettes, when would you consider to withdraw medication? And interestingly, you can see that in Europe, in children, it is considered earlier than in adults. It is around 2 years on average. For adults, there is an extreme variation from very shortly to very long after having reached seizure freedom. You can also see that in the US, epileptologists very strictly follow the 2 years recommendation. It's a completely different picture than here. We also asked them, how is this for the surgical situation? You can see that in children, in general, the tendency to withdraw is lower than in adults. In Europe, we had a median duration of seizure freedom of 1 year before withdrawal compared to 2 years in the United States. So we do that much earlier than in the US, which is probably also related to the European time to stop study findings. We also asked them, what do you think is the maximum risk below which you can advise to withdraw? And there's a huge variation here, but the median is around 25%. In children, that risk is a bit higher than in adults. So this means which kind of risk of relapse would you accept and still advise to withdraw? And interestingly, 25% is really low. So this means that doctors can think that it's only safe to withdraw if the risk of a relapse is lower than 25%, which is rarely the case. And it's much lower than the drug initiation threshold, which is related obviously to the definition of epilepsy and the risk of a next seizure being more than 60%. So it's an interesting observation that we are apparently in clinical practice very conservative here. If we look at what are factors that would influence the recommendation to withdraw, we found that it's more likely to withdraw if we are treating children, if there are side effects, of course, if the patient underwent surgery versus not, if the patient is longer seizure-free, and if there's a normal EEG. So even if we have models, the next question is, how can such a model influence this kind of decision-making? And this was studied already in 1993 by the MRC study group from the large 1,000-patient drug withdrawal trial. So they counseled a group of patients about their individualized risk. And before the counseling, they asked, what do you want to do? You want to withdraw, continue medication, or you still don't know? And then they looked at what their idea was 2 weeks after being counseled with their individual risk. And you see that the proportion of patients who wanted to continue increased from 30% to almost 80%. So hearing a concrete number being attached to your relapse risk apparently makes you more hesitant to withdraw. And the same holds true for doctors, because in this AAN survey, we asked people, what is your tendency to withdraw, likely or unlikely, in specific vignettes. And then we asked them again after we told them what the calculator came up with for the risk. And you see that the more likely people were to recommend withdrawal before they knew the actual risk, the less likely they were after having heard about the risk. So knowing about the individualized risk makes people, patients, and physicians less likely to recommend, particularly so when doctors were likely to recommend before knowing this. And obviously, if we truly want to counsel patients, we need to have two-arm calculators where we can actually compare the risk of withdrawal versus the risk of continuation of drugs. And that's not in the models at the moment. We do know from previous studies that I referred to that there's a factor 2 increase in relapse risk 1 and 2 years after withdrawal compared to the ones who stay on medication. But this obviously depends also on the group, on the individual risk factors. And we tried to compare this a little bit in a recent study where we tried to pool data from 3 cohorts of patients, both continuing and withdrawing patients. And you can see that the risk over time gradually increases in both the withdrawal group and in the continuation group, but the factor by which it is increased decreases over time. So in the beginning, there's a higher difference between continuation and discontinuation compared to many years later. And actually, this is also evident from the 2-year seizure risk-based model. So if you look at the baseline risk for a patient and you try to see what will be the risk if you continue or if you withdraw your medication, for instance, 2 years after that decision, you can see that there is a net increase of risk that is obviously much higher with a higher risk, but the relative increase of risk is not proportionally increasing with a higher baseline model. So the median absolute risk increase is 90%, and this is reflected by a number needed to harm, so meaning number of patients where you would have to withdraw medication to cause 1 recurrence, and that is 14 in the very low risk group compared to 3 in the 50% risk group. And no individual patient factor influenced this increase in risk of withdrawal versus continuation of drugs. So let's go to the conclusions. Most of the recommendations nowadays still are based on a very arbitrary 2-year threshold of seizure freedom. It's just a continuum, and the longer you wait, the lower the risk. There is a very wide variation in estimated relapse risks. This deprescribing is discussed in very few patients, only a third. We have a disproportionate low risk threshold to advise withdrawal of medication. When we know or see the individualized calculated risk, it will reduce the likelihood to withdraw for patient and for doctors. We really need to learn more about what the perspectives for a patient are, what would be the factors that would influence this weighing between the benefits and risks in an individual when coming up with a decision. The existing models all show only moderate performance with the C-statistics of 0.7 and not more than that, and they need to be improved. And if we come up with new models, we ideally have models where we have both risk calculated for the continuation versus the withdrawal stage. So drug withdrawal itself unveils the natural history of epilepsy or the success of a surgical procedure without influencing long-term seizure outcome. In the decision to withdraw drugs, benefits should be weighed against the carefully assessed individualized risks, and these individualized decisions should be made together with the patients, knowing the risks and also the consequences of a relapse. Thank you very much for the invitation again and for your patience and attention.
So thank you very much, Professor Brown, for this excellent and very detailed talk on the drug withdrawal. I think there are more questions than the answers after the talk. Before going to the question and answer and looking more details about the anti-epileptic drug withdrawal, we might have some Indian perspective in relation to the how the patient's perspective about the drug withdrawal in India, and what is the usual practice of the senior people working in the field of epilepsy. So initially we can start with Dr. Surya, his perspective on that, and then maybe Dr. Mamta.
Thank you, Chaturbuch. I think it is a very challenging question because you cannot have a generalized statement that, look, it's 2 years or 5 years or 10 years or lifelong. So honestly, every patient has to be weighed. What kind of epilepsy they have, what age they have, at what point of time the anti-epileptic drugs were started after the epilepsy has been diagnosed. Because in India, you know that many of these patients comes after 2 years, 3 years of the seizure. So many of these patients, till they get 8 to 10 seizures, they don't even take a treatment. So these all things associated along with EEG abnormalities, MRI abnormalities, that all decide. Till few years ago, we were following 5 years seizure-free. If EEG is normal, patient has been no complicated epilepsy, start withdrawing, which has changed over in last 5 or last decade to 2 years. But I still find that with 2 years, the recurrence rate really goes back up to the 50% in our practice, in my practice at least. And therefore, we really need to discuss with the patient how many patients are ready to take a risk of say 30 to 40% of seizure recurrence after stopping the drug. So these are some of the challenges which we have. However, it is an individual choice, and depending on the patient and the discussion, as Dr. Brown also mentioned, that family, the next to kin are very, very important to discuss along with the withdrawal of the drug. Again, the withdrawal has to be very slow. It cannot be a fast in say 4 weeks or 6 weeks or 8 weeks. It has to go very slow in our practice. So these are my
Can I ask questions,
observations.
or is this like an interactive discussion, or do you
Yes,
want
yes,
us
yes.
to?
Please, please. Yeah, yeah.
Of course.
Okay, that's a very interesting point that you were saying. I didn't address that yet, because you're saying it has to be very slow. There is not that much data about it. There is a review that more or less suggests that 2 months withdrawal of one single drug, I mean over 2 months, is not more dangerous than over 4 months or something like that. So we tend to take like 2 months, but I don't know how you do it, and it may also differ whether or not there is a remaining drug, or is this monotherapy or polytherapy?
So there are data which says about 6 to 8 weeks, but there are data which says about 6 months. You have to be very careful with drugs like phenobarbital and clonazepam and clobazam. So I always believe that rather than giving a statement, reduce it in 3 months' time, I think best thing is in country like India to go slow and give 3 to 6 months of time to withdraw the drug. Single drug, at least. Not 2 drugs can be withdrawn together. And particularly phenobarbital and diazepam derivatives should be very, very careful and should be very slow.
Yeah, if Dr. Mamta wants to add before we take some questions to Professor Brown.
Yeah, sure. So thank you very much, Professor Brown. That was excellent. Of course, it did not really kind of lift a lot of doubts that one has. I think there is still, even in the data that you've shown, I mean, there are ranges, and then there are variables which, can skew results after withdrawal one way or the other. So, I mean, finally, I feel we are still left with a lot of uncertainty. I must confess, I haven't used this, the algorithm that you were mentioning. I haven't, but I'm interested, and I plan to test it in my clinic when I'm there next. And I wonder if, as a group, children behave differently from adults. As an adult neurologist, I feel maybe there is a difference. Medical versus surgical groups, of course, I think there might be difference, because if your surgeries are complete and, the lesions are removed in their entirety, maybe we can have better outcomes as compared to a lot of times where we do not even know the etiology. The scans are clean, the EEG also may or may not show anything. That's one. Then you mentioned cure in one of your slides, but the International League goes to a lot of pain in insisting that, it is just a resolution and it should not be declared a cure at any point. And also they say that the resolution is when a person is 10 years seizure free, and 5 of which have to be off drugs. So that seems to be a rather a departure from most of what you presented. And then again about the taper, if the drug is suppressing the seizures, okay, then the drug needs to continue. But if the patient is seizure free now, and we assume that there is, because they are in remission, then I guess you should be able to, withdraw the drug relatively quickly. You don't probably need to linger on for many, many months or for a long time. So and should we also, pause in starting treatments? Should there be more? Should we be more circumspect if somebody, for example, has had only say 2 seizures 6 or 8 months apart, nothing else, either in their scans or to suggest that there is a very virulent disease, then should we be revising that definition? We were trying to hurry it on and saying that in some patients do it after even 1 seizure, but if the seizure recurrence, like if we are generally tending to overestimate the effect of or the benefit of drug, uh, I don't know about even about treatment.
Probably the question is that whatever data which has been presented, that at least we are sure that drug withdrawal doesn't alter the natural history of the disease. So patients who are going to relapse
I would
will,
like Professor
and
Brown to do that.
so we are coming to that, madam. So thing is that there is a certain risk or certain fear that sometimes withdrawing the drug might precipitate a refractory or drug-resistant epilepsy. And there has been some data, obviously uncontrolled data regarding that. So what will be your thought on that, Professor Brown? That
I would like to differ. Do we really have evidence that you lead patients to resistance by withdrawing drugs? Professor Brown can, of course, comment.
No, I don't think well, there is a group that does not regain seizure freedom after restarting medication, but we don't know if the same thing would have happened if we wouldn't have continued. So we need to have studies that longitudinally look at final seizure freedom and regaining seizure freedom after restart of medication in the withdrawn group compared to the ones that are still on drugs and need more drugs because they recur and tend to develop refractory epilepsy. I don't know if we really know that, but can I come back to a few points that you were mentioning before? So one of them is the point of cure. I was mentioning cure just from the perspective of the idea of a patient living without using drugs and without having seizure. That's not something we would tell to our patient. I would never say to my patient, you are cured. I will always try to counsel them as a exponentially decreasing risk over time, not being zero after 5 or even 10 years, but the confidence will grow over time with years. So the term cure perhaps is not good here. It was just to easily summarize the fact that there are no seizures, there's no medication, which may, for the quality of life and the perception of the patient, be relevant, but it's not an evidence of cure. I completely agree with that. And the other thing you said was interesting about the epilepsy surgery and the prediction. You would say in some patients you know that you did a complete resection and the patient have a good outcome. I thought so as well, but then there is this model of predicting epilepsy surgical outcome developed by the Cleveland group. That model doesn't work very well, very low predictive ability. And very recently they studied this model by comparing it with 20 experts. So they asked 20 experts to have a look at 20 individual patients, and they asked, try to predict whether this patient will be seizure-free. And guess what? Their C statistics of these experts was below 0.5. So poorer than flipping a coin. So I think we are not so good in this. Disappointingly, some were good, but most of us we are not. So that's a complex thing. And that's also why the model is so complicated. It can, as you said, it's like a range of risks that you'll be at. Probably the model works very good for the very poor and the very good outcome patients. But somewhere in between 30-40% and let's say 70% is a very large group where still there is a considerable chance of remaining seizure-free if you withdraw, but also a considerable chance of having a relapse. And the patient doesn't know, obviously, which of the two groups he belongs to. So the discussion in those patients doesn't really change having the risk. So that's the complicated thing about, I'm not so sure either. I use it more and more often, but also I tend to see more and more the relative meaning of such a model and its limitations. But the discussions are also with the patients getting more and more complicated because many patients want your advice. And I'm very honest on it. I cannot advise you. I can only tell you what we know, and that's disappointingly. I cannot really individualize, predict your future. So you have to take that chance or not. It's up to you. And that's for some parents very nice, but for others it's disappointing, and they want just a strict advice, which is not possible, I think.
Or KR sir, you have some question?
Just 2 points to Dr. Brown. The first is the individual prediction. Although these models are there, as you told, it's still inadequate. We are not able to be precise. So what do you think is the role of machine learning and artificial intelligence in the future to better predict it? And number two, in the same situation, we know basically that epilepsy results as a result of inherent genetic predisposition, whether you take of genetic epilepsy or acquired epilepsy. So do you think in the future, including the genetic data, the genetic profile to these models will make it much more precise? That is number one question, both together. And number two is, you told as far as post-operative outcome is concerned, we found that, including this is from Dr. Athod's study, another study, there is significant difference between the temporal and the extratemporal. Extratemporal epilepsies more often tend to relapse because of various reasons like incomplete resection, and more often the etiology is cortical dysplasia or fibrosis, which are with their resection could be limited by the eloquent area. So I think mixing, I don't know whether the Cleveland study mixed between the temporal and the extratemporal. I think they have to be separately analyzed, without which it's better to get a kind of the comprehensive kind of opinion one can give. You cannot equate between the relapse in temporal lobe surgery versus extratemporal surgery.
No. I agree, and the Cleveland study is not about drug withdrawal. It's not included. The recent brain study that is from the UK that includes patients that looks at drug withdrawal. So, and I'm not sure if temporal versus extratemporal was one of the significant predictors. I have to look it up, but it's very likely that it is. But more importantly, we have to still realize that these models were just based on the ones who withdraw. So, as you're right, if you think this is a very poor outcome patient because it was an SEEG patient with an extratemporal focus and no clear MRI, for instance, you probably will not withdraw. So these are not included in the model that is developed. So that makes these models very complicated to use. The other thing is very valid. So as you say, artificial intelligence, well, perhaps these kind of models is already a very mild form of AI. You know, you use data, you pull them together, and you ask the machine to come up with the most relevant predictive factors within that data. And of course, the more data you use, the better. But the question is whether or not we should pool all these patients and come up with all these data, and how we will get the data. That will be very complicated. Or if it isn't better to specifically look for subgroups and try to model specific groups rather than an entire pool. I think that the weakness of the models that we have now is that it is a very heterogeneous cohort, and probably we will learn more if we try to repeat these kind of modeling in only children below the age of 6, or only non-structural, non-lesional patients, or only patients with a known genetic background. I mean, then probably you can more specifically individualize the risk. Because one of the drawbacks of the models is, as you said, there is no imaging data included because it was not available from the older cohorts. There's no genetic data included, which should be. But this is evolving and developing so rapidly that to truly use that, you would have to make a prospective kind of model where you can look at current diagnostic modalities and include those in the model to see if it would work better. We don't have that. Another approach could also be to use even the genetic data, not in terms of the monogenic disorders with the single gene abnormality, but perhaps even like polygenic risk scores. that
Absolutely.
may contribute to the risks of having epilepsy in the first place, but perhaps also still having epilepsy after withdrawing of the medication. These kind of things have not yet been done, but they sound more promising than the kind of data that are now included in the model.
Thank you. Thank you.
Could I add something? The recent thing, what is happening?
Yes, it is.
So, Dr. Brown, it's very interesting. I have been on the Government of India panel of brain-computer interface and has been attending the various meetings internationally. And there are a couple of presentations yesterday and today from China on the brain-computer interface and how they are using it to detect the epilepsy and treat the epilepsy. So these are some 300 channel EEG from which they are collecting the data, which is being transferred to the mobile or to the computer, and they could predict that which patient is going to get the seizure. So I think the brain-computer interface is going to be a real in future to predict the epilepsy, and maybe when we withdraw the drug and check it after some time on those data and could predict that this patient is going to get seizure again or not. I think maybe we are still down the line 1 decade, but I think these are the studies already being done both at China and Taiwan, and I'm very sure that this will be the future. So this is just for information.
Absolutely. But the question is whether you can use that, of course, in the non-lesional, non-surgical group. And I think there are other similar approaches to probe the excitability of the cortex, for instance, with TMS, non-invasive techniques to see how excitable the cortex is. And you could see if that is predictive of a recurrence after drug withdrawal. So another thing is that I really would like to see if HFO, for instance, would add to the prediction of having recurrent seizures if you withdraw medication. So there's much more to do, but it's very difficult probably to find cohorts with enough power to find the predictive ability of these kind of new techniques. Even if you would find differences between the group that recurred and the group that did not recur, the differences have to be very large to have a predictive ability in clinical situations. So that's rather complicated, I think, but interesting. Yeah.
Thank you.
So maybe the two practical questions. One is some of the patients who have these surgical substrates like FCD, focal cortical dysplasia, or hippocampal sclerosis, and a proportion of patients, they do become seizure-free with medicines. So would you consider drug withdrawal in those group of patients at any point of time? Maybe let us say after 5 or 10 years or something.
That's an interesting one. I'm a child neurologist, so I'll take it one step further. We actually nowadays would operate those patients. So if a patient has a lesional epilepsy with a very concrete, well-localized, non-eloquent lesion, like an FCD type 2, AVM, hippocampal sclerosis, something vascular, etc., and the patient is free of seizures with 1 or 2 drugs, we discuss with the parents the 2 options, which is either continuing drugs and probably not trying to withdraw because we know the risk is quite high of relapses, versus early surgery with very limited risk in inexperienced hands, of course. And in our group, at least in our patient population, almost all parents choose a surgical approach. And we are operating more and more patients with 1 drug being seizure-free if they have a lesion. So personally, I would not consider withdrawing medication in such a cohort. We know that there, of course, we have people that walk around with an FCD with no seizures as a coincidental finding. But the ones who present with seizures and need drugs or get drugs and become seizure-free, the chance that they will eventually be seizure-free without drugs is very low.
Exactly.
So I would not easily do that. But that's also a bit of a personal risk estimation.
So that's a very new perspective, at least that patients who are seizure-free with medicine, we will offer surgery. That is, I think, in future it is going to change the practice of epilepsy to a great extent.
Yeah.
patient becoming seizure-free with a well-defined lesion and having a good surgical outcome or expected outcome. So as of now, the standard practice has been the surgery for the drug-resistant epilepsy.
Of course,
So,
yeah, I know. Yeah.
And secondly, in your practice, which patients, apart from these group of patients, which we think are very, very difficult to withdraw? So in which you will be very hesitant or very reluctant to withdraw?
JME.
If I had several attempts of withdrawal before with relapses, I would be careful. The ones that at some point in time needed polytherapy, so if a patient needed 3 or 4 drugs and eventually after 5 or 6 years becomes seizure-free, took a long time to become seizure-free, then I also would be very reluctant. But in general, I think we underestimate the possibilities of withdrawal, or at least reducing, because that's another thing, you know, particularly in the children with the very severe epilepsy, the developmental epileptic encephalopathies, where we just add drug to drug to drug, and we have sometimes 5 drugs. And then we should teach ourselves that sometimes it's better to diminish rather than increase. And this is something that's a new way of thinking. I have to keep reminding myself, try if the patient really needs 4 drugs. And sometimes you can try, if they're really bad, they have many seizures, you can actually try to withdraw all, and you find at the end of the line that it didn't make any difference. So it doesn't mean that you should accept the fact that the patient is drug resistant, and you still have to think about other ways to alleviate the disorder and to improve quality of life. But sometimes the withdrawal is better than changing or adding medication.
Would you comment on JME? What do you do in JME?
What we do in JME?
Yeah, how early do you try?
Well, this is the model also I refer to. I don't treat adults, so that's easy for me. I would continue drugs until they run into adulthood, and then they go to you. But the study learns us that if a patient is like 40 years and he's 22 years seizure-free, he has actually, I think, I don't know by heart, but it's like a 20%, 25% relapse rate. Not that high. You can try that. But in the younger ones, I just keep them on drugs. Yeah.
Yeah, so usually the recent data at least has shown that after 40 years, 1/3 of the patient can come out of the medicine. And some of the predictors are at least seizure freedom of 5 years and age after 40 years with a normalized EEG, and probably having no seizure except probably myoclonic jerks and generalized seizures. So in those group of patients, at least a trial can be given after 40 years of age.
40 years of a long time, Chandru. It starts.
This is not this is not a dichotomy. I think, again, as we showed, this is the largest study ever being done on the subject. It is a continuum. There's a risk decrease with every year that you're seizure-free longer. So it remains, for some patients, perhaps 50% risk is worthwhile trying to get rid of the drugs if they have side effects. Yeah. For others, it isn't. So it's similarly difficult, except from the fact that the general risks are higher. But the old idea that you can never discontinue, that I think that's not true.
So that it's still now it was believed that JME is a lifelong disease and you have to continue lifelong. That perception is at least changing.
We do have long-term studies. Yeah, people do remit, but it just takes too long.
Yeah. So yes, sir.
I have one question for Dr. Brown. How much importance you give to the EEG? You have a patient who has been seizure-free, you withdraw the drug, his EEG is normal, you have withdrawn, 1 year no seizure, and then suddenly after 1 year you find that his EEG is grossly abnormal, generalized spike and wave. What do? You give him medicine or you still observe him?
To be honest, I wouldn't have made that EEG. We only make an EEG before we decide whether or not to withdraw, because it has some influence, of course, and that's logical. And then we don't make, I know in some countries, they regularly keep making EEGs, which poses you very complex questions, and we don't have true answers. So we don't do that. If the patient has a relapse, we know what to do. We will treat. And normally we don't make an EEG, except, for instance, the patients with previous ESAS or sleep-related problems, and you don't know what's going on, or if you're in doubt or whatever, then we would make an EEG. Otherwise, we don't. This discussion actually was really interesting. We had a similar discussion with colleagues from Bonn University. After epilepsy surgery, they admit every patient after a year, I believe, for a 24-hour or even 48 hours EEG, because they say you may miss seizures. But that's a very complicated ethical issue, actually, because many of these patients, they think they're seizure-free. And in many of those, it has been decided to withdraw medications, and they're doing well. So who are we helping with this EEG finding? It's a very complicated discussion. I really don't know. If we have hard proof that SUDAP risk would exponentially increase, then you had a justification to doing this. But we are in the Netherlands at least a bit reluctant. And I think also my colleagues from the Time to Stop, for instance, consortium, we don't make regular post-operative EEGs, and also not in the ones that were medically treated.
Very good.
So maybe one last direct question. Suppose a patient of cryptogenic focal epilepsy, normal MRI focal epilepsy, had maybe 6 or 8 seizures before, seizure-free with one medicine. What will be your time threshold, normal intelligence, normal cognition, time threshold to withdraw in that patient? See,
I think I would look at the calculator, because I don't know it by heart, and I would enter several years of seizure freedom to see how that would influence the risk. And I don't think after 2 or 3 years in this particular patient, if you're sure it's not a lesion and you haven't identified a genetic cause of focal epilepsy, I don't think waiting 2 or 3 more years makes any sense. But again, if this patient has no side effects at all, is living alone, had previous seizures that were quite threatening, and who's driving a car, I would say just continue. If you're fine, I don't need to withdraw it.
So that again drives the point that it has to be individualized, and you have to take into account the patient's perspective, social aspects, family aspects, and many other things before really contemplating and going ahead with the drug withdrawal. I think we have discussed many aspects of the drug withdrawal, and at least some of the aspects, I think we all are very clear on that aspect. And with the experience and the data from the Professor Brown, I think it really helped all of us. Thank you very much, sir, for joining us and enlightening us. And it really has been a wonderful to listen to you and learn from you. Thank you very much.
Thank you. It was a pleasure. Thank you so much.
Thank you, Professor Surya and Dr. Mamta, for joining us and for this discussion. If Dr. Mamta wants to say the few words.
I would just like to thank Professor Brown. Of course, I don't think I share Chaturbud's optimism about there being a lot of clarity. I still have a lot of doubt, but I look forward to using the tool that you mentioned, and I will let you know how it goes. And I must thank Chaturbud. He's organized an excellent series of talks for the subsection, and I think this was the grand finale, very, very important topic, and I'm sure our viewers have learned a lot. So thank you very much, everybody, and good night.
Good night.
Thank you, sir. Good night.
Thank you. Good night.